Now I'd like to introduce our keynote. Remember when we had our opening remarks, we defined three major areas of discussion today. As we move into Know It, we have the LDH vision for a thriving Louisiana with Pete November, the CEO of Ochsner Health, Dr. Ralph Abraham, Louisiana's first Surgeon General, and Dr. Pete Grogan, the Deputy Secretary of LDH. After serving in various leadership roles at Ochsner Health since 2012, Pete November has led innovations in digital medicine, telehealth, and forged critical healthcare partnerships, including a public-private collaboration with LSU Health Shreveport and a joint venture with MD Anderson Cancer Center. Pete's focus is to make healthcare more affordable while delivering improved clinical outcomes and services for patients. Dr. Abraham, a practicing family medicine physician and a former United States Congressman, serves as Surgeon General for the Louisiana Department of Health. He supports state health care initiatives across Medicaid, public health, and emergency preparedness. Doc holds degrees in veterinary medicine from LSU, later earned his medical degree from the LSU School of Medicine in Shreveport, and has participated in humanitarian missions worldwide. In this informal chat, Pete, Doc, and Dr. Krogan will discuss current state of Louisiana's health and outline LDH's vision and priorities for the future. This session will provide a comprehensive overview of the state's health landscape and strategic goals. Panelists, please come forward. We'll get started. Welcome.
Good morning. It is great to see everybody here. I'll just start out to say, on behalf of myself and behalf of Ochsner, it's just a huge honor to be with everybody in this room. We look forward to working with all of you, learning from all of you. Doc and I were talking about politics earlier and just a little bit of the divisiveness in the country. One thing we can all agree upon is the right thing to do is make people healthier. And I agree with Matthew, when you see a room full of people like this from different parts of the state, different parts of the country, different organizations, it does give you hope that we can make this state healthier and we can do things better than we're doing them today. And really appreciate you taking time to be here. And I will say on behalf of myself, I'm really excited to spend time with these two physicians who take care of patients every day and are doing great things for our state. And I look forward to having a discussion and learning from both of you.
Well, thanks, Pete. And wow, what a great crowd. Thank you guys for coming out. This shows commitment and dedication, and that's what it's going to take, as Deborah and Matthew said. The format here will be somewhat changed. I pulled Pete in at the last minute. The Surgeon General's office, it's, as you know, newly created, and I've got Dr. Weitz Taylor Coleman as the Deputy Surgeon General. He's an ophthalmologist practicing in Shreveport. But with Pete as our deputy, we kind of are the three amigos of the Surgeon General. It takes all of us. Pete's an addictionologist practicing still. His intellectual knowledge of LDH far surpasses mine. He's been there before, understands the programs, and his wisdom and intellect is going to be very important to this conversation. So at the last minute, I asked Pete to join us, and he graciously said yes. So we're going to have a good discussion. Go ahead, Pete.
Yeah.
Thanks, Doc. You can't always predict the day, and we roll with it, so yeah. Yesterday, we didn't predict that someone would faint during a press conference, and we rolled with it, so hopefully everyone stays well today, but happy to be here.
Pete, thanks for being here with us. Doc, just first question to you. You're the first Surgeon General, and I'll just say, what a great position that is. When you think about where our state is and the fact we need to get healthier, it makes all the sense in the world to have someone who gets up every day and thinks about that, and someone who's a physician. So what's your vision for the role and sort of creating this role? What did you want to accomplish?
You know, I've got to give credit to Governor Landry. During our transition meetings, we were having the discussion about just what Deborah and Matthew are talking about, where we are in the stack as far as chronic disease, diabetes, hypertension, you name it. we're not where we need to be. We're giving right in the middle of the national ratings the money per patient to treat those things, but we're not getting the outcomes that we need. The governor knows that. The transition team knew that. So what Governor Landry wanted is a person or persons that were practicing physicians that continue to see these patients on a daily basis, their needs, their wants, their hopes, and portray that or move that needle down the road where we actually have input. So, Pete, to your question, we as physicians, we are going to direct healthcare policy. Everyone in this room knows that LDH is a huge beast. We're fortunate that we have Drew Moranto as our Medicaid head. We've got Michael Harrington as Secretary of LDH. Those guys are going to do phenomenal work. But it's a big job. So if we can move healthcare policy out of their wheelhouse, put it in ours, then we can be more focused, more targeted, and more direct in our ask and our wants also. So that's where we're going. We're going to break down silos. We're going to establish relationships. I personally want to thank Ochsner for this healthy state. Ochsner is phenomenal in many ways as far as the state's concerned. You guys are, of course, one of the bigger employees, if not the biggest. Y'all bring innovative, motivative ideas to the table. So it makes our job as Surgeon General and at LDH easier when Ochsner and people like this group create programs like this that we can kind of pony off of. We don't have to reinvent the wheel. You guys have already done it, and we can just kind of latch on and contribute.
Pete, you want to add anything?
Only that I couldn't probably think of a better medical specialty for the Surgeon General than Doc's role as a family doc. And for anyone that knows his practice, he takes care of everything that walks in the door, and you can't care for the individual patient as a primary care provider without taking care of the family and then taking care of the community. And I think you'll see that underpin a lot of our policies.
And you can bring your dog in too. No kids.
You know, when Ochsner created Healthy State, I just want to say it wasn't about Ochsner. It was about really when we looked at healthcare, not just in Louisiana but in the country. It is about the only way to fix it is to make people healthier. We talk all the time about hospitals and physician clinics and people going in and getting care, which is always going to be important. But just from a macro perspective, we have to make people healthier because we're not going to have enough physicians, we're not going to have enough money, we're not going to have enough resources and long term unless we do that. And so that's really what it's about, and it's about us all working together because it's not going to be any one person that can do that. I will say we've been excited since both of you have been in your roles that we really are able to work together, and you all are really taking the leadership on this initiative, which we think is fantastic, and we want to support you any way that we can. What are your big priorities to keep people healthier? That's a big statement. Let's make people healthier. If you said, okay, you know, these are the 4 or 5 things we really want to focus on, what would those be?
I'll talk about the SHIP. It's the State Health Improvement Plan. This is something that the department used to do periodically, and to be honest, I think ended up as a report on a shelf, wasn't touched. When we came in January, we had our transition team goals, and then one of the first briefings I had was with our SHIP team, and they had over 6,000 interviews, community work groups. It was a 2-year process, and their 4 main buckets were maternal mortality, behavioral health, chronic disease, and community safety. And it was an identical overlay with the transition team goals. I mean, it was one of those policy moments of alignment where you're like, we're onto something here. So that's the big 4. I will highlight the extensive overlap between the maternal mortality and behavioral health buckets because, as many of you know, we're one of the worst states for maternal mortality. I don't know if folks know the #1 cause of maternal mortality in Louisiana. Do folks know that? You can probably it's a little biased because it's my specialty, but overdose is the number one cause. So as we improve our behavioral health infrastructure, we're going to improve our maternal mortality, but there's more we have to do in both of those categories.
And with this SHIP program, it dovetails into Ochsner's Healthy State program. I mean, as Pete said, there's a lot of overlap. There's some individuality, which is needed and wanted. But when y'all launched this in, 2020? The SHIP program was launched just, this past year, this fiscal year. We looked at that and said, hey, this is good, and we're going to kind of follow you guys' leads.
Yeah. We were excited when we saw that because we're like, great, it overlaps. And I know there was a lot of good discussion about that. And I think for people that aren't maybe involved day to day in a relationship between health systems like ours and the state, you should know there's almost daily discussions about making the state healthier. And I'm seeing Christy sitting over there, and I know she's probably been down to meet with Pete and Doc and others and many people in this room many times. And so there really is, in the last, really since the transition, there's been some great conversations on a daily and weekly basis about how we make the state healthier. And I could just say that's really been exciting for us to see your commitment to that.
Well, when I was watching Deborah's and Matthew's slide, they put up that slide that had kind of the different colored flags. And if you looked up on that left-hand corner, there was East Carroll Parish. That's Lake Providence, Louisiana. That's in my wheelhouse. It's in my congressional district, but I see patients from Lake Providence. And not only is it the poorest in the state, it's one of the top 5 of the poorest in the nation. And I've said it, you'll hear me say it again and again, because in my heart of hearts, I believe it. I've never come across anyone that wants to be poor. I've never come across anyone that wants to be unhealthy. These are good people that need our help becoming healthier. I'm sure Pete will get into it deeper in the discussion, but we're pretty good at docs of giving that lecture in the office, motivating that patient, and they walk out the door, and for about 2 days, they do what we tell them. But then they fall back into their old ways. They smoke. They do this, they do that, and things that they know are unhealthy, but it's such a inherent way of their lifestyle that they continue to do it. And we need Healthy State SHIP program from LDH and other programs which Pete will talk about in a minute, to have that follow-up, to have that continuum of care, so that when they take my advice for 2 or 3 days, somebody else or something else picks that up and shores them up, boosts them up, so that they will continue to help themselves.
You mentioned community safety as one of the key issues. And, I think sometimes we think about healthcare in isolation and don't think about that, as the slide Deb and Matthew showed, it's not just about delivery of healthcare, but also the efforts going on to make the state more safe from a crime perspective, and all the work going on from an economic development perspective, because all that ties together. Because when people have jobs and they have resources and they have hope, and when they feel safe, turns out they're healthier. Can you talk for a minute about that relationship? Because I know it's not just you all working at LDH in healthcare. The governor and other parts of the administration are also working on those issues, and it all ties together.
I'll hit it first, and then Pete, I'll turf it to you. And again, I'll get a little bit ahead, but we're going to talk about it anyway. So, if we talk about it, and this is Dr. Pete's life work, and he's very good at it, but that behavioral health and crime are tied at the waist. We know that probably 40 to 50% of those that are arrested have some type of behavioral or mental issue. And Pete sees that every day in his practice. And if we as physicians, if we as healthcare providers can intervene early before that patient commits a crime, not only have we done a service for him and his family, but economically for the state, we have saved the state a lot of money because they don't become incarcerated and they don't fall into that circle that just keeps, where they recidify over and over again. Pete, I know this is up your alley.
100%. I mean, I think everyone in this room sees it every day. My wife is on a trauma surgery hour 26 or so call right now, and I never get more addiction curbsides from her than when she's on trauma surgery. And that just shows you the overlap between behavioral health and community violence. I think great chance to talk about what I think is our most exciting initiative at the department, and that's our reentry waiver, our 1115. So if I can go briefly into the policy weeds. Basically,
Go for it.
Go for it. Can I get in there? Okay. The feds for the long time had something called an inmate exclusion. So even if someone was eligible for Medicaid when they got incarcerated and were eligible when they left, we couldn't cover any of their treatment services while they're incarcerated, which, to Doc's point earlier, is a rare moment of stability maybe in their entire life where we could treat their addiction and their mental illness. We're applying for a waiver to allow us up to 90 days before they're released from both jails and prisons, and I'll come back to that because I think that's an important distinction, to treat their addiction, treat their mental health, get them plugged in with a community psychiatrist, get them on a formulary that we know is their Medicaid formulary, so when they're released, their medications are stable, actually give them medications in hand when they leave the jail so they're not navigating the pharmacy system, which we know is hard if you weren't incarcerated for the last 12 years. And I think the piece about including local jails is key. A lot of those people that are incarcerated there don't have a clear release date, but we were able to ask the feds for, if their average stay is less than 90 days, can we just go ahead and cover these services for the duration of their jail, even if it's not set in stone? And they give us that flexibility. I think we'll be the first state to actually do that. And we know this is where folks are coming in, detoxing, getting off their antipsychotic, and then they're stuck in the churn. They end up in our psych hospital waiting for competency restoration. And really what they needed was a long-acting injectable that wasn't available because when that jail gets $23 a day for their room, board, and medical care, they're not able to pay for that medication. I think if the consequences fall to Medicaid, I think it makes a lot of sense from a preventative standpoint, which is sort of the theme of today, to go upstream and do preventative behavioral health.
All right, while we're on the topic of behavioral health, and I actually see Dr. Dean Hickman over there. Dr. Hickman is a psychiatrist, and he oversees and runs all behavioral health for Ochsner. And turns out he's probably one of the busiest people in our entire organization. And I'll also say one of the kindest, most caring physicians I've ever had the pleasure of knowing and working with in my life. It's a huge issue, access to behavioral health, and one that's really complex. What are your all's thoughts on where do we start? What do we do to help that?
Well, we do have some programs in place. I'll speak about a couple of them, and then Pete probably has some he'll speak about. But as it stands today, we have a mobile crisis response team that if we get a call that someone's having a very bad day, in an urban area like Baton Rouge, our goal is to have someone with them within an hour. And if we're in a rural setting, like in my neck of the woods, maybe 2 hours. But that's still a good response time. If that can't be resolved there and then we can move them to a brief center where we can give them longer term. We can move them to a facility where we can give them up to 15 days of treatment. And during that 15 days, if we know that they're going to need something more downrange, then it gives us time at LDH with our wonderful people that work with us to set up those appointments, those follow-ups, those things that, again, will just hopefully help them from falling back in that trench that they can't ever crawl out of.
I think that's a great point on the clinical infrastructure. I'll make a plug for a workforce initiative that we implemented within the first 2 months because we know that is definitely a rate limiting step for access. And this was a change around provisional licensing. So folks that are in training, licensed clinical social workers, therapists, We know that a lot of them actually end up practicing in carceral settings and safety net settings because of an experience they had when they were training. They walked in and said, you know what, I was scared to ever walk into a jail, but I actually love this work. Like, these are my people. I can make such a huge impact. I want to dedicate my career to the people most in need. It was unfortunately financially burdensome for anyone to train them, though, when you couldn't bill for their services. So that supervising clinician would have to go and do the same service that the trainee just did so they could actually get reimbursed for it. It made no sense for a lot of reasons, and we changed that, I think, within 30 days of being in office. So that's just for behavioral health providers at this point. I think we'll have to look if we can expand that. And then one other big initiative, and I think it reflects sort of our approach to innovation at the state level, is not that we should be issuing top-down ideas that we came up with on, in the Galvez building over there, but in Lake Charles, there was the bridge program, the expansion that they've done there around getting people connected from when they overdose and go into an emergency department to outpatient providers that can manage their addiction. It's this incredible, it took 3 years. It's one of the only regions in the state that actually decreased overdose rates over the last few years. And it's because of this brute force infrastructure that they really built. We're looking at how can we take a shining light, an innovative example, and scale that up statewide.
And going back to Pete's, what he does for a living, on the addiction side, what we've done at LDH also, mostly with Pete's guidance and forward-looking thinking, is provide naloxone to patients that heretofore didn't have access to them. Now, everybody in the room knows that naloxone's not the cure for our overdose epidemic that we're having, the fentanyl crisis that we are all living through. Everybody in this room knows someone that has either overdosed or has died from a fentanyl overdose. But at least if we can prevent a death and give that healthcare provider, give that hospital a little time to intervene with that patient, well, maybe we can save a few lives. And certainly with Pete's guidance on this naloxone program, we're not only giving it out almost in drive-throughs, but now when a pregnant lady comes in having a baby and we know that she has a substance abuse issue, we can intervene then and help her from reusing and falling back into that terrible morass that we all know exists.
Switching gears to access and screening and keeping people healthy so they don't have to come into our hospitals. I will say from my perspective, you mentioned safety nets. One of the things that I've really been most proud of and where I've seen such a big change was actually up in Shreveport when we put that partnership together. And as you know, you trained there, but it was really built upon people coming to an ED. It was built upon people coming to the hospital, not about trying to treat people before they got sick. And one of the things that together with LSU we've been able to do is put community health clinics, do screening, get out in the community and give people access before they end up in ED. And the other thing we've seen across the state is everybody has a cell phone. And we had some of our digital hypertension and diabetes program, and a lot of people thought, well, that wouldn't be for the Medicaid population. But again, everybody has a cell phone, and we talk a lot about that population. They're the folks that don't have the chance often to leave work and go see their physician. And so today we've got, I think, 7,000 patients on it that we're paying for. The results are incredible. Doc, I know you've dedicated really your life and your career to giving people access to health care in a rural community, and I know that is your passion. So I guess for both of you, how can we help? What do we need to do to increase access and also go upstream and get to people who, before they get sick?
I think the biggest challenge I feel like in making these initiatives sustainable is that there's no way to capture the savings of prevention. I think this is probably maybe the biggest challenge in health policy more broadly, is how do you measure an averted event and then translate that into resources to actually expand and improve care. I think that's where the creative financial models come in that many folks in the room are working on. How do you do shared savings contracts, outcomes-based contracts, value-based payments? I think that's the vision that this department has for the relationship between our providers and payers. I think that's the promise of managed care, is that there's some flexibility to really enter into these creative types arrangements. I think that's harder when their utilization is too low. It's the difference between Medicare Advantage and Medicaid. A lot of MA patients have overutilization, and there's clear ways that you can improve their coordination of care and save both sides money. I think in Medicaid, obviously, especially for kids, arguably there's insufficient access to resources and social services. So any way that we can kind of think creatively about that whole patient care and that whole family care, I think through these value-based payment structures is sort of the key.
Yeah, and I'll hit it from the rural perspective because that's where I live, and it's difficult, as you said, Pete, that to touch that patient rurally. In my little practice in Rayville now, we open the doors at 6 o'clock in the morning. It's not because we want to get up early, but what we have found over the years is if we're there early, those people that have to work, they can't miss a day of work or they lose income. They'll come, we'll treat them, and they'll go to work. So the apps are good. I'm of old school. I like to have that physical bond with that patient, but I'm also a realist, and I know that that's not going to work for most everybody else. So we have to have the innovation and motivation that Healthy State SHIP program has created to access those patients, going back to Deborah and Matthew's slides, talking about rural health. In our rural communities, we know that even in Louisiana, and even with primary care, there are still a lot of health deserts that those patients can't access. That's why we have, I think it's 23 critical access hospitals that are funded in a little bit of a different manner, try to give them a little more money to stay open so they can see those patients. But in Louisiana, in rural parishes, the rural patient has an income of about $10,000 less than someone here in Baton Rouge. The number or the percentage of high school graduates are lower. The poverty is just greater in rural Louisiana as it is across entire America. And that's the access that you guys, hopefully we at LDH, are starting to reach and make some inroads.
If I could add one quick thing. Helps to open at 6. Doc's been up for 3 hours and ran 3 miles before then as well. But I think the Ochsner model is a great example of not just focusing on the device itself. I do think these digital solutions are key in the rural areas, but the wraparound services to get durable outcomes. I think that a lot of the early pilots, you give someone a remote cuff and they use it for a couple weeks and they end up on a shelf, especially for older patients. But I think the Ochsner model is a great exception to that, and that shows the role of the device in a comprehensive network of care.
You mentioned value-based care, and again, we're all in on that. I mean, fundamentally, when you think about it, you have to go there. I mean, you've got to get to a place where people, instead of getting paid for providing more care, they're getting paid for outcomes and to keep people healthy. One of the things I know both of you as physicians experience in that world every day, though, are the regulatory barriers. I can't get my patient into home care who needs to go to home care. I need to get this done, but I can't get it done. And will you just comment on that? Because I know I've talked to both of you about your commitment to addressing those issues.
We could spend the whole day on that. I would say 90% of these gray hairs on my head are dealing with that exact issue, Pete. Whether it's prior authorizations for a generic drug, come on, that's been out 50 years. Whether it's trying to get home health for a patient with a cellulitis that I know with the proper home health care I can keep out of the hospital better for the patient, better for the economy. It's just, it's mind-numbing of where we go. Now, again, I'll go back to Governor Landry during the transition. He said, make it go away as much as you can. Drop these barriers, drop these silos. And what Pete can tell you, he's been more intimate on the conversations than I have on the LDH side. But we are having very tough, deliberate, extended conversations with our managed care organizations to that point. Do their job, screen for us, they're getting paid to screen, and give us outcomes instead of giving us studies. So, Pete, I'll let you comment on that because you've been doing a deep dive on it. But
Yeah, I mean, I think that's spot on. I think it's changing the philosophy of saving money by just restricting care and utilization management to smarter payments and paying for and incentivizing the plans to actually capture some of those savings, right? I think that's where the department comes in. I think that's our role to reimagine the relationship between us and the plans to where that incentive is built in.
I'll just give a little my thoughts on that. Because I feel you and I have talked about this. Like, we have 2,000 people at Ochsner whose job is to deal with certifications with payers. 2,000 people. Think about what we could do with those resources if we could put them into healthcare as opposed to those issues.
in my little clinic, I've got 2 people that all they do every day for 8 hours or sometimes more is try to get some approval, either a MRI, I mean, it's over and over. So, yeah, and, we pay pretty good, so, we have to have these employees just to keep the doors open because we won't get anything done.
Yeah, I mean, I feel strongly. People, doctors, nurses, people that go into healthcare, they don't go into healthcare to think about money. They go into healthcare to think about doing the right thing for the patient. And I think we got to give them the latitude to do what they do and take those regulatory barriers away, which are really actually impacting the care that people are receiving.
Absolutely. To your point exactly. All the money and economy that we're spending on that could be used on the patient.
It could. All right, we'll get off that topic because we could go all day on that one. Pete, you mentioned maternal health. How do we give babies a good start? How do we help moms be healthier so that we can address that issue?
Yeah, obviously it involves expanding outside the episode of delivery. I think this, to the credit of many of the folks in this room, our delivery-related adverse events have really decreased over the last 10 years. I mean, there's plenty more work to do, but I think we're seeing that the greater contributors to maternal mortality and the disparities around maternal mortality come from that prenatal episode and especially the postnatal episode. Over 50% of maternal mortality happens greater than 6 weeks from the episode of delivery. I see it all the time in my addiction clinic. So many moms are able to not use during pregnancy, and then you imagine the chaotic transition of coming home, especially with your first baby, maybe to an unstable household, the stress, you don't have a follow-up appointment until 6 weeks, no one to call, and you had an untreated substance use disorder that whole time that you were just sort of barely holding on. I mean, that's maybe the most chaotic episode of care for anyone in this state. So I think the naloxone distribution at discharge, which is not a prescription but a bag of medicine, you don't want to be walking out the hospital with your baby and go wait in a Walgreens line to get a preventative medicine. So I think that's a key piece, but it takes a comprehensive strategy. Doc, actually, one of his first meetings was pulled in a war room of our policy experts and said, give me a plan. He said, I want a white paper in 1 week, and I want everything that we need to do, and I don't want to hear that docs are going to push back or plans are going to push back. If it's the right thing to do, put it on the paper. And we said, okay, all right. And we've got that, and it's not a plan that, again, sits on the shelf. We've changed it probably 7 times. I think actually there's probably 7 different versions of it at this point. It's about infectious disease screening, blood case management, syphilis screening and treatment, the widespread behavioral health stuff that we've talked about. It's really looking at that whole package of care. So if there was one silver bullet, I think other states are dealing with the same thing. They would have figured it out. We're going to use our resources to try to experiment. And then also one other, I think, source of innovation is going to be this broadband funding that is still early, but it looks like there's going to be some non-deployment dollars left over for us to innovate around telehealth-enabled strategies. And we're going to focus on the same goals that underpin our department: behavioral health, chronic disease, maternal mortality. But I think especially in the maternal mortality space, there's so much opportunity for innovation. You know, that mom has a cell phone and no one's checking on her about how's your mood. You know, are these baby blues or is this postpartum depression? That's something that you don't need to drive an hour for in a rural area to go wait in a waiting room and see someone. That's something that could be done with a text message. So I think a lot of innovation to come.
And I'll just add on there, and again, I give a lot of credit to Dr. Pete here. What we found is that that new mom, she's not going to come in for herself. She'll bring that baby in, okay? And that's where we can capture mom. So if we know that she's coming for a well baby visit, we get tuned up that we ask the questions about addiction, about depression, anxiety, all those things that we can help if we know about it. So that's something that is ongoing, and it is really, really having some good outcomes. And I'm sure everybody in this room knows Vineeth Ingenar. We love Vineeth. You can tell him that. He's helping. He's the broadband guy for Governor Landry. And he has allowed LDH to join in with some broadband money that was left over from some federal issues. Pete is using that wisely. Him and Drew and Michael have put together a wish list of what you said, Pete, as far as telehealth, the internet, the broadband. And that is going to come to fruition very quickly in the next 2 months, right, before the end of the year. And it's going to be put to good use.
All right. Among the very complex issues in healthcare, certainly in the top three is workforce. I mean, we have, you know, at any given time in the country, I've seen data anywhere from probably 80,000 to 100,000 shortage of physicians. I think we all know that, you know, we can't train enough nurses, and it could go on. And I think one of the biggest issues for any healthcare organization in the last few years has been workforce. We also know we have an aging population. It turns out you need more people in healthcare in the workforce to take care of the aging population. What's your thoughts on how do we train more people? How do we keep more people at home?
Talk about the Hero Fund.
Yeah, Hero Fund's the first thing that comes to mind. That's something that in the last legislative session was transferred to our department, and this is basically a grant-making initiative that requires a match from the folks that are receiving the grant, but it's to partner private sector and educational institutions to address, I think, relatively strategic workforce challenges in each area. So there's definitely broad, you know, not enough nurses, not enough physical therapists, not enough docs, but it also varies slightly by region, and I think the goal of this program is to reflect those variations, at least hit the highest need in each area. So Drew Moranto, our undersecretary, has really been spearheading that. We got about a year to spend. I think it's $17 million, and I hope that's going to make a big impact.
And if you look at the studies and the statistics that we get at LDH, and I'm sure you get them too, Pete, as of today, we need in Louisiana 500 nurse practitioners, we need 1,500 LPNs, and I could take 5,000 RNs today, and they would be absorbed immediately. Fortunately, there's been an increase with some training. We've got to do a lot more. We're projected to need 10,000 RNs in the next few years. So if you don't have the workforce, what I can tell you, and Pete will admit it too, I am literally dead in the water without my help at the clinic, whether they're RNs, LPNs, rad techs,
Yes.
lab techs. I can open the door to my clinic, and it stops right there without my help, okay? They are such an integral part of my life that if I don't have them, I don't do well. So yes, we've got to have those people.
Yeah. You know, we at any given time have somewhere between 2,000 and 3,000 open jobs for people in the healthcare workforce, which is both a healthcare problem and economic development problem too. So it's really important. I will say the last time I was in Governor Landry's office, one thing I've learned about him, you may go in and talk about one thing you think you're talking about, but he always has something else on his mind. And we went in with actually one of the universities in the state to talk about something, and in the middle of the conversation, he just switched totally. He goes, so Pete, he goes, how much have you guys had to spend in developing partnerships with universities around the state, which we were super happy to do, and it's been a great thing. And I said, probably $50–60 million. And he pointed at this particular person from the university. He says, isn't that your job? He goes, isn't the state funding you guys to help us create the workforce? And so I just say that because I know that's his focus. He's got a big focus on how do we fund and direct the education program to create that pipeline.
Yeah, the governor, like we all want in this room, we want people to come to Louisiana, but more importantly, we want them to stay in Louisiana. We are training these people, they're coming in, and then they're leaving. And we're fixing to have, I think, a special session on taxes and all. These are the people that we in Louisiana need for our tax base. And these are our working people, our professionals that we need to recruit, we need to manage, and we need to hang on to. So the governor is well aware, and that's what he wants.
Yeah. I've learned in my job, I spend so much time thinking about communication. It turns out I can have a good idea sitting in my office, but if I don't share it in the right way, it doesn't really go anywhere. And I know both of you experienced that. So because we got an audience from people across the state, how can we help you communicate? How do you think about that? How do we get the word out there on what we need to do to change the health of Louisiana?
I think it starts with a shared vision, which is what we opened this conversation with. I think that's huge, knowing that we're all healthy state, governor, ship, everything's aligned on those three major priorities. I think that's key. I feel this so acutely in the public health space, where I think a lot of trust has dissipated in terms of our public health institutions, and that is really, really tough on the team that's trying to take care of the community. I think it starts with transparent communication from us. It's evidence-based. It's sharing information, but not telling people, I think, how to live their lives. I think it's that hitting that balance of accessible messaging and communication, but allowing people to make their own decisions. And I think that's Doc's philosophy as well.
Yeah, and everyone here in this room, we all know politicians. We all know faith-based leaders. We all know business leaders. And you have got to constantly remind them, us up here, of what's important. We all chase that bright and shiny thing. Sometimes just doing the right thing every day over and over is the hard thing. Going to work every day is for all of us, getting up, doing that routine. It's not bright and shiny, but it's necessary and it's important. So everyone here, you've got to have those conversations, and you've got to pigeonhole us, get us in a corner, and make us listen sometimes. And that's a hard conversation, but that's what it's going to take.
All right, Pete, since you've had a surprise day already, I'm going to hit you with a totally surprise question. So I was looking at your bio. I mean,
It's impressive on Pete.
Yeah, I know.
I carry his bag.
I know, that's the same thing. I know. Doc, I felt the same way when I looked at his bio. And so, he went to Yale, trained at Mass General. You could do anything you want, but you chose to come back and work at LDH to try to make Louisiana healthier. What drives you? What made you do that?
I think if you look back at my personal statements, maybe from college to residency, I kind of recycled the same theme. I mean, it really was rooted in growing up in Crowley, in Acadia Parish. I think I was so frustrated with how bad medical care was. I saw it with my family, I saw it with my grandmother, I saw it with my parents. I think that I knew I wanted to change healthcare policy before I knew I wanted to become a doctor. And that was sort of a later realization, and still want to do the two. And then the more I traveled to these other places, and the training has been incredible, but I see there's a room full of people that's trying to do safety net rural addiction medicine outside of Boston. And I was like, if y'all just move to come down here, I'm the only one in Crowley like trying to do this. The need here is so great. I think being at home is also just an absolute privilege. So for me, it's doing work that feels meaningful, and then, I love life down here in Louisiana. So having fun at the same time is great.
And I'll continue to embarrass Pete even more. Our salary is public knowledge. A person of Pete's integrity and his education could be making 5 times what he's making. And so he's got the heart of a lion, the soul of a saint. So I've told Pete, his wife, wonderful person, but she's becoming a problem because she has got a fellowship now in Canada. So I'm putting a restraining order on Pete.
Right.
I'm trying to put one on him and his child. So it's a work in progress, but we've got to keep Pete in Louisiana.
Yeah. Doc, I know you're a pilot. Sounds like in addition to carrying his bag, you might have to be his pilot too.
I am looking at all options.
Yeah. Pete, I'll say on behalf of the state, thank you for doing what you're doing, because you could go anywhere. And again, I've had the chance to work with you a couple different times at LDH, and every interaction with you, you care deeply about what you're doing, and you're doing it for all the right reasons. And so thank you.
Thank you so much.
Yeah. All right, Doc, we're going to hit you. So you've been in the military, been a veterinarian, you've been a physician, been a 3-term congressman.
I just can't keep a job.
I know. Look,
keep letting me go.
Well, that's what I say. Like, I had every other job at Ochsner I kept getting fired from, and there's only one left, so that's how I got mine. So look, you've done all these amazing things. I guess 2 questions. Look, right now you could be back in Monroe, running your clinic, hunting, enjoying life, but you chose to do this. So what made you want to do it? And then the other question is, what's really been the most fulfilling thing for you throughout this incredible career you've had?
Well, Pete, I'm no different than anybody in this room. I mean, why are you guys here this morning? Okay, it's because you want to make a difference and you care. So we all have the same goal. I'll give you a quick personal story, but it kind of, sends home as to why we all do this stuff. Well, we could be somewhere else doing, lay on the beach, whatever. I get bored very quickly at the beach, by the way. So a couple of weeks ago, when the hurricane hit North Carolina, I flew over there, did some work, and in my helicopter with Travis Parley. Now, Travis is a retired state trooper from Louisiana, phenomenal pilot, so he was flying with me. And Travis was actually flying the helo this day. We were flying over, taking supplies, and it's horrific there. It's a mudslide, this power line, everything is terrible. You've seen the pictures. And Travis has the eyes like a hawk, so we're popping along in the helicopter. He says, I think I saw something. Okay, I said, circle back. And he did. And here is this family waving on the top of a mountain where they had the mudslide, and we knew they needed help because they had access to nothing. We could hardly find a place to land. There were so many downed trees and power lines. We finally found one, but it was off-site from where these people were. We landed, there was this, it wasn't in a prison yard, but there was a fence around this place like a prison. High wire, barbed on top. Finally got to the people, cut through with the chainsaw, that fence, pulled that fence over, and what came out? A pregnant lady having contractions. She was in active labor. He loaded her out. I stayed on the ground. Travis took her to a pickup truck because there were no ambulances available. Got her to the hospital. 2 hours later, had a baby. I got a personal email from this family. I don't know how they found out who we were. Just thanking us for what we did, but that you guys here, Pete and Pete, would have done exactly the same thing. We do what we do because we want to do it and we care. So that's in a nutshell, Pete. We just want to help people. But it turned out she had a baby girl, 8 pounds, 6 ounces, and everything's good.
It is a blessing to get up every day and work in what we do. Because at the end of the day, I mean, we've talked about a lot of complex things, but if you got to keep this focus. It is about taking care of people in their time of need. That is what we do, and it is a blessing to get to do it. Before we finish up, Doc, I want to give you the chance to talk about your favorite topic, which is not healthcare. 10 grandchildren. I mean, what's that like?
Who would have thought I would get to this age, Pete? My God. I'm like Deborah. I don't feel my age. I'm sure I look my age, but look, I love my grandchildren, and we live on a farm. We tell them to be home for supper, or what we call here dinner, and don't kill yourself before then. And they're out on the farm. They come in sometimes muddy, oftentimes bloody. But they've learned life lessons, and they've learned them by trial and error. We try not to give them sharp objects, and certainly nothing with the firearms. But that, Pete, is my passion, my love. Watching them grow, watching them mature as they should, as they get older and older. And hopefully, from my standpoint, Diane, their parents, we teach them some stuff that you guys teach your kids and your grandkids. Again, everybody in this room, we're all the same here. We all want the same thing. We want a good life, we want a good family. But as healthcare providers and people that can influence healthcare, we want those people that we treat to also have that quality life that we're fortunate to have. And we strive for that every day.
That's great. So before we wrap up, you've got this whole audience of people. Any last words for this group that you want to say?
I guess just a thank you, because this work is not easy. It's going to be hard. I think that I think the hardest part at a healthy state or any sort of population level initiative is not necessarily getting that one-on-one feedback that you see from a patient. I love it when I get it on the direct, on the front lines, but I hope you'll keep in mind at least an archetype or a vision of the patient you're helping, the mom with substance use disorder, the dad with diabetes, the kid with autism, that if you make a policy change or a high-level change is actually tangibly going to improve their life. And I just hope you get a chance to meet that patient one day. So thank you.
I couldn't have said it better.
Wow. I'll just finish by saying first, thanks to both of you for serving. Both of you are doing it for the right reasons. You're both focused on doing the right thing for the patients and for the state, and thank you, because you could be doing a lot of other things, and we, as a citizen of Louisiana, we appreciate that. I want to say thank you to everybody in this room. It does give you hope when you look out here and think about all the different people from different parts of the state and different parts of healthcare or the community. We can do this. We can make this state healthier. We can make change. We can help you someday find that patient. And it happens by us, just breaking down the walls and the barriers that divide us and working together and staying totally focused on our role, which is to make people have a better life, make them healthier, and make this state better. So I hope you have a great day, and thank you for taking time to be here, and thank you for what you do every day.
Thank you, Pete.
Thanks.